A very good evening, ladies and gentlemen. Welcome back to yet another Sunday with Online Dentistry. Kindly wait for a few minutes while we enter all our participants. I, on behalf of Online Dentistry, would like to thank you all for the enormous support that you have given us. Kindly wait for a few minutes while we enter all the participants. Meanwhile, please make sure you register yourself on our website to claim the certificate of the webinar. We'll be starting our session very shortly. Once again, a very good evening, everyone, and welcome to Online Dentistry's Periodontics made easy for all the dental practitioners. Before we start our program, I'd like to show you all a small video about how online dentistry has progressed all through these years. Thank you, everyone. Our motto is to redefine dental education in multiple places and in multiple times. Our numbers suggest that our firm was established way back in 2008. The total number of offline classes that were taken are 122, but the total number of online courses that are conducted till date are more than 500. We can proudly now say that we are a family of 20,000 plus people on global platform. Coming to the masterminds of the whole show are Dr. Joby Peter Sir, MDS, Head of the Academic, Department of Pediatric and Preventive Dentistry, Anu Dental College, Kerala, and Dr. Vinuti Ibrahim, CEO, Kerala Dental Clinic, Online Dentistry. Well, as we all know, online dentistry is filled with a lot of session and we don't go let our Sundays go in vain. So we have an amazing conference coming up that is organized by Anu Dental College Kerala in association with online dentistry. We have Dr. George Paul Sir, who's a great lawyer, a renowned academician, and an extraordinary practitioner. He's going to give us a few secret tips and tricks about how to bust dental trips, dental myths, and to have a very smooth dental practice. Along with that, we have another international guest speaker, Dr. S. Karthikeyan sir, who is going to give us a detailed session about how facial aesthetics and function can be approached with orthodontic surgery and change a person's appearance. Well, this conference is one of its kind. We have 8 international guest speakers coming up, so you cannot afford to lose them. So, ladies and gentlemen, without wasting even a minute, click on the links and register yourself for this upcoming Horizon Unlimited. Well, coming to the most public demanded oral habits demystified. We just concluded a session expansion, and I would like to again thank you all for giving us such a great support on this. Now it's time for you to grab the opportunity to take the seats for this because the registration numbers are going high and we have seats limited. So grab your seats right now. For any updates, stay contacted to us on these 2 numbers. Well, cutting to the chase, I'm coming to the most awaited periodontics for general dental practitioners. Sir is today going to demystify and tell us small tips and tricks about how periodontology can be taken in our dental practitioners. No more is going to be a gray area. Definitely, we are going to have a very clear approach about this. And to introduce Sir, I'd like to invite someone whom I am inspired by every day. I learn from him each day and every day. Dr. Joby Peter, sir, please take over the screens.
Thank you, Dr. Devika. Am I audible?
Yes, sir, you're clearly audible.
Yes. Good evening, all. I hope everyone is safe and sound in a respective place. What a support that you have given to us in this evening, Sunday evening program. Now, to introduce, to get into my duty to introduce you, Professor Dr. Jose Paul, sir. What I want to tell you about sir is before anybody in this platform knows sir, I know him because he was my senior in my graduation, and means in my plus school, he was my super senior. From that time onwards, I know sir, I know his dedication, and from there, sir has gone in to do his BDS from Vinayaga Mission Dental College. He finished his BDS from Vinayaga Mission Dental College, the prestigious institute, and has done his MDS in periodontology from Government Dental College. You know, he is a person to meet, an academician, a teacher, a guide, whatever in your practice aspect you meet him, sir will give the guidance there. Sir has kept or hold very prestigious post in Indian Dental Association Kerala chapter and been the best CDE all India. His way of interacting with everyone, taking each noted values in practicing dentistry, applying it is amazing there. Sir also has so many publications. I am not going into those things, but sir is a practitioner, a academician, a great orator, a teacher, a guide that inspire, motivate, and support everybody in any state with respect to the professional things. So I'm so much honored my own school great person have excelled in dentistry coming in our online platform and giving and delivering and accepting our offer to deliver. Sir is so busy, but sir has said I will come and delivering this lecture. Sir, thank you so much for accepting our offer and doing it for us. And all the stage is for you, sir. We are waiting for you to demystify periodontics, one of the gray area which we general dentist doesn't take it seriously. Over to you, sir. Thank you so much.
Dr. Joby, is the screen visible?
Yes,
Am
sir.
I audible? Am I
Yes,
audible?
sir. Perfect, sir. Perfect. You are spotlighted. Perfect, sir. You can start, sir.
Well, good evening, all. Thank you, Dr. Joby, for that wonderful introduction. I don't know whether I've been introduced in a much better way anywhere near the future. Thank you. And I'd first like to thank Dr. Joby as well as Dr. Binu, whom I've been associated for long periods of time, for inviting me to this international platform. Now, I have delivered many lectures, and a similar lecture was delivered for an idea branches, and Dr. Joby took you and asked me to present this for the members of online dentistry, and here we are. Now, before going into the actual lecture, let me tell you, I'm not going to talk about anything rocket science. I'm going to talk to you about basic periodontics, which you practice in everyday life. What I want you to do is, or what I want you to is to make you understand the reason why you are doing certain things in a certain way. And if you are doing certain things in a certain way, it is going to yield you maximum results. Now, when you look at periodontics, I know I've got about 180 participants now. And when we look into this, definitely many of you would have been practicing perio for a long period of time. Perio in the sense that you may not be practicing speciality of periodontics, but probably doing some sort of perio, at least a scaling. And there are a lot of patients who have come with perio problems, and you would have dealt with all these patients. But what I want you to do now from this lecture or after this lecture is to unlearn some things that you have been doing so far. What is unlearn? Unlearn is to learn something new. Now, you forget something that you have been practicing. Probably it was right at that point of time, but now things have changed. You have seen your senior practicing and you have followed the same. Probably that is also something wrong. Now, the reason why I am telling you all this is because I've been a practicing periodontist for more than 20 years, and I've come across many non-periodontists. I've been a visiting consultant to many clinics, and I've interacted with a number of general practitioners, non-periodontists. And from that data, I can say that 95% of those population which I mentioned are not able to identify an early periodontal lesion. Now, stress early periodontal lesion. So what we are going to do or discuss today is we are going to discuss some basic aspects of periodontology. As I told you before, nothing rocket science, not much theory, some basic practical aspects of periodontology. And at the end of this lecture, if at least 10% of you are able to diagnose and plan a treatment for a simple or an advanced periodontal problem, then I consider myself job done. With this as an introduction, let's go to the lecture. Now here, I don't have an iota of doubt that anybody over here can identify an advanced periodontal lesion. Now you find an advanced periodontal lesion here. Now it has got all the characteristics of an advanced periodontal lesion. You can find there is recession, lot of deposits. You can see the gingiva is inflamed. You can make out without a radiograph that there is going to be interdental bone loss, all features of inflammation, everything. Now, if you clinically examine, probably most of the teeth will be mobile, and if you take a radiograph, there will be generalized bone loss. Now, this is a case which all of you are going to identify in your practice. I know that. Now, let's look at another scenario. Now, this is another scenario where you find some spacing between the tooth. Okay, some gingival inflammation is there. Now, when you examine more, there may be pockets, and when you take a radiograph, you may find so much of bone loss in that patient. Now, this is also a case which I'm sure that 80% of those who are listening to me today are going to identify this as a periodontal case. Now, I want you to stress on this picture. Now, when you look at this picture, picture looks absolutely normal. But is it normal? Is it a normal gingiva? This is actually a patient who has come for orthodontic treatment. Now, as a periodontist, when I look, I feel that in this area, I find something. What I find that the normal, the contour, the color, everything in respect to that aspect is a little bit different. The stippling is lost. Now, I'm worried about a little bit about this area too. This also area is not similar to this area that is present here. So if you take a radiograph, now this is the area that you're going to focus. Now look at the amount of bone loss in relation to that area. And what happens when you open up that area? You find that there is an advanced bone loss with a lot of deposits in that area. Now, imagine doing a periodontal treatment, an orthodontic tooth movement in this case, and what it would finally result. So these are cases which I want you to identify. If you are able to identify these cases, then job done. Now, first we'll look at clinical diagnosis. Now, as I told you before, clinical examination is the best method, And you can take a radiograph to supplement your clinical diagnosis, microbiology and biochemical, leave it. Now, that is for theory, that is for PG, that is for research. But clinically, what you should do. Now, this is you see these two pictures. In this picture, you may note that, you can see all the features of a normal gingiva, stippling, normal contour, consistency you can make out, but everything is there. And here you may find that there is spacing between the tooth. But even if there is spacing between the tooth, if you clinically observe the gingiva, what do you find? You find some amount of stippling over there. Now, what I want you to focus is, whenever you see a patient, I also used to do the same. We always focus on the tooth. We always look at the size, probably the color of the tooth, the angulation of the tooth, whether it is caries, whether it's discolored, and all those things we'll be looking into. But we never look and observe into the gingiva. So what I want you to do from now is to look and observe into the gingiva, and the gingiva has certain subtle changes which gives you a basic idea that there is an underlying pathology. So that is what I want you to focus upon, right? Now, in this case, even though there is a spacing, you find, look, that the gingiva is stippled over here. That itself gives an idea that there is no pathology over there. Now, look at this area, there is spacing, but you see a depression over here. If there was a pocket over there, if there was a periodontal pathology over here, what would have happened there? The gingiva would have been inflamed. So just looking into the gingiva, you can make out that there is no underlying pathology. So that is what I want you to focus now. I want you to focus on the gingival tissues so that you will get a good idea about the underlying pathology. Now, this is the case of simple gingivitis. You see all features of gingival inflammation. You remove the plaque, everything will come to normal. But the next case, next level, what do you see? Now you find a patient like this. If there is going to be bleeding comes, what will you do in this case? Now, what is the reason why there is so much inflammation here? The inflammation is because there is a periodontal pathology there. There is some etiology that has contributed to this inflamed gums. Okay, so that is something that you will have to examine and find out. Now, what you find here, you find that the probe is going deep here. And look at the color of this area from this area. This area you can find that is slightly bluish or grayish. Now, this exactly is when you observe, you can find that there is a pocket. Now, I've been practicing periodontology for probably about, as I told you before, about 20 years. And I can clearly say that I, along with my fellow periodontists, can, because we are trained to identify most of the periodontal problem, not all periodontal problem, most of the periodontal problem, just by examining or looking into the gingiva in one shot without even taking an X-ray or clinical examination. Now, I don't want you, all of you, to do that because you're not trained so. But at least if you observe, you may find subtle changes which will give way to an etiology that is present underneath. So that is basically what I want you to take home. Now, this is a simple instrument, periodontal probe, that is going to be helpful in diagnosing most of your periodontal problem. But there are different ways in which use it. One is even you may find a furcation involvement also, which you cannot detect by means of your regular periodontal probe. For that, you need a neighbor's probe. I'm not pretty sure. I'm not asking anybody of you to buy a neighbor's probe, but if you are able to use the round end of your explorer, well, job done. Okay, but there is a way by which you should probe. The technique of probing is known as walking the probe. Why is walking the probe very important? Now you find a case here. Now you probe here in this relation to this, you take it out, then you move here, then you probe here, then you take it out, and then you move here, and then you probe here. Now this method of probing is known as walking the probe. Now, I'll show the importance of walking the probe. Now, this is a patient that came to us. Now, he has got a complaint of spacing between his upper central incisors, and his upper right one is slightly extruded. Now, when we examined, we found that there is a deep pocket in relation to this tooth. Now, when it was surgically explored, this is what we found. Now, suppose we probe this area, that is this area, you may have a pocket of probably 3 millimeters. Now, suppose we probe this area, you may have a pocket of probably 5 or 6 millimeters. This is going almost to the apex, probably about 14 millimeters. Here about 6 millimeters, here about 3 millimeters. So that is the importance of walking the probe. Suppose you're going to probe this area and try to move this area here, probe here. Will it move? It won't move. That is why you have to probe around a single tooth in different aspects. Mind you, in your practice or not in my practice, nobody has ever come to me saying that he has got a periodontal pocket. He has got a periodontal problem. He is going to come and tell you that he has got bleeding gums. His gums is bleeding. He has got bad breath. Doctor, my teeth are becoming loose. My tooth are spreading out. Now there is some swelling in relation to my tooth. Now, when the patient comes to you, it is your duty now to identify whether there is a periodontal problem. You have to identify, you have to check whether there is a pocket there. You have to check for recessions there. You have to evaluate the mobility of the tooth. You have to check press around the tooth to find exudation, which means that there is an active periodontal lesion there, or you have to look for furcation involvement. No patient, unlike an ortho patient or a prostho patient, is going to come and ask you seeking specific treatment. No periodontal patient is coming. But there are patients who come and ask you bleeding gums. But what we do, we simply do a scaling, or we ask them to apply some topical medication, and we send the patient. Is it right? It is not right. As in the subsequent slides, I'll explain why it is not right. Now, briefly, I'll explain to you about etiology of periodontitis. This is just for completion's sake. Okay. Now, and it is very important also in this presentation. Now, this is an old paradigm which shows you the pathogenesis of periodontal disease. Okay. Here, on one hand, you have the bacteria. Bacteria means plaque. Plaque means it is mainly mostly made up of bacteria, and the other hand is called host. So whenever there is plaque buildup, the bacteria produce a lot of factors against the host. The host produce an array of mediators against the bacteria, and there is going to be a host bacterial interaction. Now, if the bacterial attack is very less, now the bacteria is controlled. Now, if the bacteria are more, or if the host is at a dilapidated condition, now bacteria takes over, or there is an exaggerated host response, which is going to cause tissue destruction in the form of collagen, which causes all the pocket to form, along with bone destruction by means of different mediators. And this results in periodontal disease. And this whole host bacterial interaction is being mediated by two things. One you can see on the top, that is acquired and environmental risk factors. That is your diabetes, your smoking, and all those things. And then below you can find the genetic risk factors. In the genetics, you may find mostly defects associated with the neutrophil. Now, whenever you have defect associated with neutrophil, it may result in periodontal disease. Not only periodontal disease, it may result in all sorts of other diseases in the body also. So this is the paradigm based on which you can describe the pathogenesis of periodontal disease. Now, let's see a case. You may find that this is a very healthy periodontium. There are absolutely no deposits attached to it. But one thing you should notice, there is plaque. And plaque is not visible to the naked eye. Now, for the etiology of periodontal disease, plaque has got a primary role. Now, when you take one small plaque sample, and if you examine, you may find 500 to 600 different types of microorganisms in that plaque. Now, out of these 500 to 600 different types of microorganisms, mind you, only 5 to 10 of these are causing pathology. They are known as periodontal pathogens. Okay? So the rest of these are not causing disease. They are commensals which are very much essential to the body. And it is these plaque microorganisms which is causing the periodontal disease. That is something that all of you should know. Now, how can you, as a dentist, as a periodontist, can you control plaque formation? No, you can't control plaque formation on a day-to-day basis in a patient. Only the patient can maintain or control plaque from being formed. So you have to advise meticulous oral hygiene measures to the patient, make the patient understand the importance of plaque, and make him do all best oral hygiene measures that are best suited to that patient. Now, the second most important aspect which has got a role in the etiology is calculus. Now, does calculus has got a primary, what is the role of calculus? Now, calculus is nothing but it is calcified dental plaque. Now, over a period of time, the plaque that you see gets calcified and forms calculus. Now, you may find calculus mostly in relation to where your salivary ducts open, the lower lingual aspect, the upper buccal aspect. Okay, but what is the role of calculus? The importance of calculus lies in the fact that calculus is always covered by means of a non-mineralized layer of dental plaque. So what is the role of plaque? Plaque is the primary etiological agent. So the calculus acts as a fixed nidus on the tooth structure, and it presents the plaque to the gingival tissues. So, and this actually perpetuates the periodontal disease. So even though the plaque has got a primary role, it is our role as a dentist to remove calculus, because the patient is not able to remove calculus once it is formed. So whenever a patient comes to you, if you are meticulously removing all the calculus from his oral cavity and then advise the patient proper oral hygiene measures, and he follows that, 80 to 90% of all periodontal problems can be solved. That is the another take-home message that I want to give you. Now, brief idea on classification, this is just for completion. Now, when I was doing PG, over the years, there have been a lot of classification of periodontal disease. And when I was doing PG, now we used to follow one classification. By the time I went for exam, we used to follow a 1999 World Workshop classification of periodontal disease. Now, After that, after about 17, 18 years in 2017, presently we are following another classification. But this is one classification which I put forward here, which is very simplified, which anybody can follow, which it makes sense for a general practitioner, for a non-periodontist. So one side you have gingival disease. This plaque-induced gingival disease because of gingival inflammation, because of the plaque. On the other side of periodontal disease, you have chronic and aggressive type of periodontal disease, which I am going to describe to you the features of these diseases. In gingivitis, that is the gingival inflammation. What you do? Nothing but you do a proper scaling, because the junctional epithelium must not migrate. There is no loss of attachment here. Just do a scaling, everything goes back to normal. Everybody knows that. Now, this is one case. Now, after just one scaling, you look at how much changes occur to the gingiva. Now, this is what I really want all of you to experience. Now, one scaling can really matter. Now, if you are able, now everybody has mobile phone. So if a patient comes to you with gingival inflammation and you find that, take a photograph. Now do a meticulous scaling and then recall the patient after 2 weeks and see how much wonder has taken place to his oral cavity just by doing one good scaling. Now, in chronic periodontitis, it occurs in all patients. There will be a lot of plaque and calculus associated with it, and it's slowly progressing. It's usually 40, 50, 60 years age of patient, because it's slowly progressing. The rate of bone loss is very less. But unlike aggressive periodontitis, which occur in a much younger age, you won't find any plaque or calculus. Very little, scanty plaque or calculus. But the problem is, in spite of reduced local factors, the quality of plaque is such that it can cause rapid destruction. At the same time, probably there is some inherent defect associated with the patient. Now, this is a classic picture of chronic periodontitis. You find all the local deposits are present. You may find all gingival inflammation is present. Here, there's migration of teeth. All these are features of periodontal disease. And when you take a radiograph, you may find generalized bone loss. Now, what I want you to focus is, now suppose you have taken this radiograph or this OPG after your scaling. What I want to focus is, I want you to focus upon these small specks that are present here. Can you see a small speck here? Can you see a small speck here? Can you see this irregularity into the root surface? You can find this in relation to this radiograph also. What are all these? These are all calculus. These are all subgingival calculus. And it is this subgingival calculus which is covered by means of the non-mineralized plaque, which is actually perpetuating the problem. So if you are able to remove that subgingival calculus, and if you are asking the patient to maintain a good oral hygiene, you can control periodontal disease. That is what I want to tell you. Now, aggressive periodontitis. Aggressive periodontitis, you find, look, the teeth are like a diverging type, the spacing between the tooth, but when you don't find any local deposits. Now, this is the radiograph also. In the radiograph also, you can see, look, you don't find any accretions on the root surface as we saw in that previous radiograph. Now, how do we manage cases? Now, that is a sequence in which periodontal therapy has been done. This is where I want to speak to most of the practitioners. Now, as I told you before, I have been a consultant to many clinics, and what everybody used to do, or what is the complaint of most of the periodontists is that whenever a case of period means that is not an early lesion, that probably is an advanced lesion, they just call the periodontist. Is that the way the work should be done? No, you should first do a phase 1, a proper scaling and root planing. Recall the patient probably after 2 weeks. You reevaluate the condition. As I told you before, if you have done a good work, 80 to 90% of your problem would have subsided if you have done a good work. And then if the problems are again remaining, I'll tell you what all problems it is remaining, then probably you can refer the patient for a periodontist, or the patient for the next level of treatment, that is probably a surgical or other phases. So that is how the reevaluation. So Early periodontitis. Early periodontitis means, no, there's no term like it, early periodontitis. Just for understanding, say, I'm putting it. If you have a shallow pocket after phase one, if you have a shallow pocket of 5 mm, okay. Now just if you are, what do a subgingival scaling. That is more than enough. If you after your phase one, that will suffice. There is no need of surgery. Okay, that is what I want to say. Now look at this case. You may find all signs of periodontal disease. There is a recession there, local deposits, all sort of gingival inflammation. Look at the size, the contour of the gingiva is changed. There is almost spontaneous bleeding that has occurred from there. One thorough phase one therapy, one thorough scaling and root planing. What it has done wonders to that patient. No surgery was done here. Now, what has happened here? Now, in the first phase, in this case, if you see, and then if you have done a treatment plan in the early phase, that is completely going to change after reevaluation. Now, what does reevaluation do? When by reevaluation, by your phase one therapy, most of the lesions would have completely resolved. You would have eliminated most of the lesion. And look at you can look at the consistency of this tissue and this tissue here. This is soft and friable. And suppose you ask the periodontist to do a surgery here, or anybody, if you just do a surgery here, it's going to bleed like anything. Can you see anything when you do a surgery? You can't. So it renders a tissue more firm and consistent. And fine. Another thing is acquaints the patient with the dental office. Now, everybody is scared of doing surgery. When at the moment you talk about surgery, everybody is scared. So by one or two scaling and root planing and you review, the patient gets acquainted with the office, and the fear of a surgery is also being reduced by doing so. So that is the importance of evaluation. So from now on, don't, even if you see, even it's an advanced periodontal case, an early periodontal case, or whatever the case is, you first, as a general practitioner, you please do a phase one therapy, a meticulous phase one therapy, and then you recall the patient after about 2 weeks and see how the condition is there. And then depending upon the condition, you manage. If you can manage on your own, or if just any recall or any supportive periodontal therapy is needed, or just recall is needed, put him on that. If there are further treatment to be needed, if you are not able to do that, you call a periodontist, you refer to a periodontist. So that is the importance of reevaluation. Now, this is a case you can see there is gingival enlargement into multiple areas. One good scaling has resulted in this. Another case, look, the gingiva is bulbous, enlarged. Inflammatory type of gingival enlargement. No surgery was done. Look at this area is bulbous still. This area is all bulbous. No surgery is done. Just meticulous phase one, where you remove all the calculus and ask the patient to maintain good oral hygiene. It has resulted in this. I'll show you one more case. Look at this case. You can see that it's so inflamed. It's almost spontaneously. Look at the size of the gingiva, the contour of the gingiva here. Now, one scaling. Look at how much changes that has occurred to this gingiva over here. So that is the importance of scaling, removing all the deposits. Mind you, there you should remove all the deposits. And you ask the patient to maintain good oral hygiene. This is the result you are going to achieve. Now, another case. If you take this is a radiograph of this case, you may find you can see this all these bulky these radio opacities. These are nothing but these are calculus over here. Now there are some stains also. You probably must be a smoker also. So what you do a meticulous oral hygiene, and this is how the post-operative radiograph will look like. And what will you do? Is there any further treatment that is needed in this case? That is my question. Now, there is a recession there. Okay, I can see that. If you take a radiograph, there is going to be bone loss there. Is there any further treatment that is needed in this case? Look at the gingiva here. Look at the picture of the gingiva. Look here, even the interdental areas, you can find stipple gingiva here. So there's a no, it's a healthy gingiva there. You have recession there. There is horizontal bone loss there, but no amount of a regenerative therapy, whatever surgical treatment you are going to do, is not going to bring back all your periodontal or gingival tissues to the CEJ. So if the patient maintains good oral hygiene there, that is the end of your treatment. You've done a good work. Okay, you just follow up the cases every 6 months. Ask the patient to come, do a proper scaling. The tissue will remain at this level. There is no further treatment that is required. Now, what should you do in case of established periodontitis? Established periodontitis is, even after phase 1, you find a pocket of more than 5 millimeters. That is probably where, as a periodontist, or you need a specialist referral or specialist help. You have a pocket of more than 5 millimeters. In spite of your thorough oral prophylaxis, that's still bleeding. You press against the gingiva, there is exudation. That means there is some amount of subgingival calculus or some etiology that is present there. You can feel subgingival calculus even after phase 1. In such cases, probably you will have to send your patient to a specialist, or you'll have to call your patient, and your specialist will have to do a type of surgery which is known as flap surgery, with or without regenerative procedures or techniques, depending upon the case. So that is established periodontitis. So this is where you need the help of a periodontist. Now, this is the case where you need to refer. Now, not in all the cases. In the first case, you see you all inflamed gingiva, pocket of 7 or 8 millimeters. That is not the time you want to refer. You do a phase 1 therapy. You find out after your phase 1, pockets are still remaining. Then, or all these features are, as I mentioned here, are still remaining. Then you can advise, refer the patient to a periodontist. Now, this is one case. The patient has got a spacing between the tooth, and you can see that there is a deep pocket. You can see that it was endodontic treatment intentionally so that to correct for aesthetics. You can see an angular defect there. Now, we did a surgery which is known as a papilla preservation flap, because there is spacing between the anterior tooth, which will be more aesthetic in this case. So this is the whole papilla is being reflected into the label aspect. You can see this defect. This is the defect that is seen. This is the angular defect. This is the defect that you see. You fill that area with bone graft and you finally suture, and this is how it heals. And this is that angular bone loss is almost converted to a horizontal type of defect over here. Now, aesthetic is not corrected. So what you have to do is, that is why the reason why we did a root canal therapy and then do a crown for that patient. Now, another case, the patient is coming with an exudation. There is a deep pocket almost extending the apex of the tooth. That slight mobility, not much mobility into that tooth. Okay. This is after phase 1 that you find. This is when the patient came with an abscess. Now you take a radiograph. There was bone loss almost to the apex of the tooth. Because the tooth was not mobile and because the tooth was non-vital, we advised a root canal treatment for this. Is the radiograph after root canal treatment. But if you look at this radiograph alone, you will say that you better extract the tooth. Now, we did a surgery in this case after the root canal treatment, and look, we placed some incisions, that vertical incisions here. And when we elevated this, just beneath this flap, what do you notice? What you notice is the cause of this pus that is coming out. It is this calculus that is attached to the root surface that has caused all this pathology. So what we do, we remove all the calculus, and because the GP was not extending to the apex, we do a little bit of episectomy also, and then we close the flap. We put some bone graft. The defect was completely filled with bone graft, and then we coronally advance this tissue. You can see recessions. So we wanted to cover this recession. So we coronally advance this tissue, and this is how it finally came to. This is how it's started, and then finally it came. Another case, I just want you to concentrate on these two areas. Okay, this is one area on the lower anteriors. This is another area of the 3-6. Okay, what you see in the radiograph here, when you take a radiograph, you see a lot of deposits in relation to this teeth, and you see deep pocket in relation to this. Even in this relation to this area, you may find, you see on the root surface. In the root surface itself, you may find, if the surface is not, you may find that there are a lot of accretions on the root surface, deep periodontal pocket. Because it was almost going to the apex, we advise a root canal treatment in this case. And this was the pre-op. And look, when we opened up this case, all these deposits that you see in this X-ray are visible in that when you see clinically. Now, this is what is actually causing all this bone loss there. So our aim as a periodontist or as a general dentist is to remove all the calculus or accretions on the root surface. So that is the point that I'm stressing upon many times. Okay, so we remove all this. Now it's plain, then we place graft, and then when we close that area. Same thing we did with the lower anteriors. I mean, lower molars also. We opened up, we have, look at the changes. Look at this outline of this root. You can see that it's so smooth over here. It's completely clean and it's filled with bone graft. And this is immediately after surgery. Now, another case, what I want to do is, now these are this patient had some trauma early on. That's why it's discolored, and he had done a root canal treatment, and he had a deep pocket in relation to this tooth. Okay, and in radiograph, you can see an angular bone loss here. So we opened up that area. We opened up in areas so that it's minimally invasive. Okay, and this is what we found. And there was a deep defect over here that was filled with bone graft. And then we placed a guided tissue GTR membrane was placed over that. And then we did a suturing. And at the same time, because we didn't want to have too much of recession here, so we advanced the flap here. So this is the suture, the sling suture that we put. And that is what on the palatal aspect, you can see the sling suture. And this is the post-op, and this is the post-op X-ray afterwards. And then later on, you will have to do a aesthetic correction for that patient. You cannot do a crown for individual crowns for that patient. Now, the important question that I want to ask each one of you here is, can diagnosis and prognosis of a perio patient be made from radiographs? Now, many people now, with the advent of latest technology, especially WhatsApp, many practitioners send me X-ray and say, "Doctor, what to do in this case?" Now, just by looking at the X-ray of a patient, I cannot give I won't have an idea about the prognosis or even the diagnosis of that case. Now, if somebody would have given a clinical photograph also, I would have got some idea. I'll tell you why. Now you see this case, excuse me. Now you see this case. In this case, you can see some bone loss over here. Okay. Now this is a CEJ. This is the bone level. Now this radiographic case can present in 3 different ways clinically. Now, this is one way. The bone is at this level. Bone is at this level. But where is the level of gingiva? The level of gingiva is at the CEJ. So there is a pocket here. Okay. Now, this case, the bone is at this level only, same level. Bone is also same. But what has happened? Gingiva is slightly receded. There is a small pocket here. Okay. Then what is the third aspect? Look, there is completely receded and almost at the bone level, there is no pocket. Pocket is about 1 millimeter. Now, just by someone showing this radiograph, how can I know that there is a pocket there? Because pocket is a soft tissue problem, and Look, if this was the case, there is absolutely no treatment that is to be done. As I showed you before in that one case, there is no further treatment to be done. Just remove this calculus and just put the patient on maintenance. In this case, probably you will have to do a subgingival scaling and see whether that pocket is reducing and advise the patient to maintain. In this case, probably the pocket is deep as 5 or 6 millimeter or 7 millimeter. You will have to do a flap surgery. So just by looking into a radiograph, you won't have the slightest idea. You have to correlate the radiographic findings with your clinical picture and then come to a diagnosis and prognosis. So that is something that I want all of you to know. Same thing goes for mobility also. Now, suppose here you have a pocket, there is no recession, the tooth is grade 2 mobile. In this case, again, the tooth is grade 2 mobile. In this case, case is grade 2 mobile. Now, among these three cases, which will have the best prognosis? I will say that I can do something, I can do some regeneration because here the gingiva has not receded. This has got the best prognosis. I can probably eliminate the pocket here, reduce the inflammation here. I can bring about some regeneration here, but nothing can be done here. And suppose if it's gone so much, the gingiva is receded like anything, you probably have to go for extraction of the tooth. So the importance of the gingiva, the level of recession or whether there is no recession plays an important role in the prognosis of the tooth. So you have to correlate your radiographic findings, your clinical findings, your mobility, and everything has to be correlated to make a prognosis or a diagnosis of a particular periodontal problem. So that is what I want you to take home. Now, this is the same thing. Now, just looking at the radiograph, would we have done surgeries on this? No. We did surgery because there was not much recession here. We could do a lot of regenerative procedures here. We could bring about regeneration here. If the gingiva has gone down to this level, would I do regeneration? Would I try regeneration? I would never. I would have extracted the tooth. So that is important. Just by looking at radiograph, never, ever come to prognosis or diagnosis. Now, another thing which I want to, this is going to the end. One thing I want to know is about periodontal abscess. Now, I have seen many dentists in general practice doing a root canal treatment for a periodontal abscess. And then later on, they find that the abscess is not reducing. And then they understand that probably it is not a periapical abscess or not a pulpal problem. And then they refer to a periodontist. Now, one of the most important thing is all of you should be able to differentiate a periodontal abscess and a periapical abscess. That is one of the most important aspects of general practice. You may find a lot of cases in your practice, and this is something that you should understand. One is one of the important aspects of periodontal abscess is if there is a periodontal abscess, there will be a periodontal pocket there. It is definitely, that is one important thing. But if it is a periapical abscess, instead of the pocket, you may find a carious tooth. The tooth may be carious, the tooth may be discolored, the tooth may be fractured, the tooth must have had a history of trauma, but there won't be a pocket. But then the second thing is the location of the abscess. Now, the periodontal abscess may be anywhere along the lateral aspect of the tooth, while the periapical abscess is always towards the apical aspect. Now, when you take a radiograph also, the periodontal abscess probably you may not be able to locate, otherwise only a chronic periodontal abscess, acute periodontal abscess, you may not be able to locate in a radiograph, but mostly a periapical abscess you may be able to locate in a radiograph. Tooth is vital in a periodontal abscess, but the tooth is non-vital in a periapical abscess. And also the pain. The pain in a periodontal abscess is much less, unless it is an acute periodontal abscess where you feel that the tooth is slightly raised up and when the patient bites, there is pain. But periapical abscess, It is extremely painful, and the pain is mostly during night. And another differentiating factor is if you find a fistulous tract, if you find a fistulous tract, it is definitely going to be a periapical abscess, because periodontal abscess rarely cause a fistulous tract. It will just drain through the sulcus, or sometimes it will be pinpoint somewhere along the lateral aspect, and it will pinpoint abscess, pinpoint opening will come and it will drain. But in a periapical, chronic periapical abscess, you may find a fistulous tract. Probably using your GP, you can trace that, and you can come to the conclusion that this is going to originate in relation to the apical aspect of that particular tooth. How do you manage periodontal abscess? One of the most important things is the chronic abscess or an acute abscess, especially acute abscess. Definitely, you have to go for drainage. You have to drain that abscess. You can drain through the sulcus, or if under local anesthesia, you put an incision on the most fluctuant abscess, insert some sort of instrument and drain whatever pus that is present. Drain, that is the first thing. Do you need to give antibiotics in all cases of periodontal abscess? There is absolutely no need for giving antibiotics. And for that matter, there is no need for giving any antibiotic for any periodontal lesion unless otherwise specified for. Okay. If there is a systemic involvement, definitely. If there are, like, if the patient is associated fever, malaise, regional lymphadenopathy, all these things are associated, you give antibiotic. If it is immunocompromised, is diabetic, some sort of problem, you give antibiotics. Otherwise, there is no need of giving antibiotics. And if you give an antibiotics, you start with a loading dose. Suppose you are giving antibiotics, you're giving amoxicillin. You don't give 500 milligram amoxicillin. Start with 1 milligram of amoxicillin, followed by 500 milligram. Okay. Then, so drainage, then antibiotics, then recall the patient, do a thorough prophylaxis, scaling and root planing, and then review the patient. And then, depending upon whether the problem is resolved or not, that is, after evaluation, you find that there are still pockets, still persistent pathology, do a flap surgery and put the patient on supporting care. What we do, I've seen many people go wrong with periodontal abscess. What people usually do is, give some sort of antibiotics, do a scaling, and then just leave the patient. What is going to happen? Probably after 3 or 4 months, he's going to come back again with an abscess. But one thing I want to make sure here is with each episode of abscess, there is more and more of periodontal support that is being lost. So the prognosis of the tooth is being reduced or lost with each episode of abscess. So if the patient comes on the first instance itself, if you can manage in the way that I've described here, then the patient is getting better care, the best care. I'll show you one case of periodontal abscess. You can see this bulge over here. There's the OPG of the case. You can see that there is a deep angular defect over here. Now, this is so because there was a deep angular defect and the tooth was non-metal, we advised root canal therapy. This was during the first phase of root canal therapy, first stage, and this was immediately after completion of root canal therapy. And even after the phase 1 therapy, we noted that we had a pocket of more than 12 millimeter here. So we went for flap surgery. This is what we encountered on flap surgery. You can see the angular defect, typical to what you see out here. This furcation is involved. This is the furcation that is involved here. This is completely lost bone. Angular defect is there. So we decided to do a grafting here. We decided to place a graft. Along with the graft, we decided to place something called as platelet-rich fibrin. PRF is nothing but a concentrated growth factors. What you do here is you take the patient's own blood, you centrifuge in such a way that the blood is separated into 3 different layers. You have the RBC, the platelet, poor plasma, and the platelet-rich fibrin, which comes in the middle. You take out this is the PRF plug that you see. And this plug is rich in growth factors. Now, what is growth factors? Growth factors are certain agents that are produced by the cells of the human body. And what this growth factors does is This aid in a wound healing. This promote the wound healing. So whatever wound healing that is present here, the migration of cells, the differentiation of cells, the formation of matrix, everything is being aided by this growth factor. So we mix this growth factor. This is an affordable mode of growth factor delivery. I mean, affordable mode by which you can, this is an easy. It's very cheap also. So what you do is you mix with this bone graft and then you place it over here. And then you close it. And there's the post-op radiograph after 6 months. You can see the difference. This is how we came, and after 6 months, and look at the difference here. Now we are ready to place a crown for. Now this is the final case. Excuse me. Now this is a 27-year-old male female who was referred to me. Now, when I took his case history, I found that this guy has been visiting so many dentists, and he was really, really perplexed. He was really confused, and many of them had advised multiple extractions. Now, I don't have a clinical picture, so I'll tell you there was not much recession in these cases. This tooth was slightly mobile. I can say that it was probably about grade 2 mobile, nothing great, okay? But there was not much recession. And he had a lot of blood tests was done because different practitioners advised different types of blood tests. All blood tests was within normal limits. So I took up this case and I told him, look, I advised him extraction of only his third molars. I told him that I'm going to save all his other teeth. We agreed for the same. And this was the result after 5.5 months. After 5.5 months. Now this tooth, this was the first cordon which I did. And during which he was so psyched. He was a young fellow, unmarried fellow. He said, please, sir, don't remove this tooth. I somehow agreed for that, but the other quadrants, I made sure that I removed the other tooth because I knew that this pocket won't resolve without removal of that tooth. But this is the result after 5 months, 5.5 months, and I'm pretty sure that there is going to be. I can see. Look, when you look at the pre and the post, look at this radiolucency here, and look at you can see some bone being formed. A little bone formation here. We did bone grafting and all relation in relation to all areas where there is angular defect. We did root canal treatment in areas wherever necessary. And this is what. And suppose in the early stage, he had listened to others. Others would have only looked at his radiograph and see, oh, this has got an advanced bone loss. We need to remove that. That patient would have lost his tooth. They have not looked into the clinical aspects of the patient. They have not looked into the mobility of the patient. They have not looked into how the patient is responded. So you just by looking at radiographs, you can't make at a diagnosis or a prognosis of a particular tooth. You have to look all around. You have to take all the aspects which I have told and then come to a conclusion and then decide your treatment plan. Now, what are the common mistakes that we make? We give too much importance to the tooth. As I told you before, we look at the inclination of the color of the tooth, whether there is caries of the tooth, the position, and all those things we do. We don't even mobility of tooth, but we don't observe the gingival tissues. If you observe the gingival tissues carefully, it gives a good idea about the underlying periodontal pathology. Now, if you are doing a crown, even if the patient is not paying you, even if you are doing an implant, even if you are doing a bridge, make sure all the periodontal pathology is removed. Otherwise, it is going to the failure of your restoration is sometimes the periodontal problem would be the reason for the failure of your restoration. Observe the soft tissues. Don't delay treatment. As I told you before, with each active abscess, so much of bone in relation to the tooth is being lost, and probably at the end, you may not be able to save the tooth. And those early lesions have to be diagnosed. That is the most important thing. If you can diagnose early lesions, you can do a pretty job. You yourself can do a pretty job, or referring to a periodontist is going to help you a lot, help you as well as the patient a lot. So take home, as I told you before, diagnosing is the key. Thorough scaling. I told you the importance of removing calculus. The calculus removal is not where the patient just sees. The patient may be looking to the mother and seeing some areas of the oral cavity, and he may feel that you have done a great job. No. Remove calculus from the most distal aspect of the tooth to wherever that is present. You look for calculus, complete remove the calculus. 80% of the pathology will resolve with removal of calculus. And as I told you before, don't make a treatment plan based on radiographs. The re-evaluation is the key. If you don't re-evaluate, if you just make a treatment plan based on what you see on the first day, that is completely wrong. You do a phase 1 therapy, you re-evaluate, then refer. If the pockets are more than 5 millimeter after phase 1 therapy, that is a case that needs to be referred to a periodontist. That is how we should take about periodontal patients. Now, if someone over here is practicing for probably about 20 or 30 years, this patient you would have seen in this level, probably about 5 years down the lane, you would have seen this case also. Probably about after 7 years, you would have seen this patient. And after about 17, 18 years, you would have seen this patient. Well, you will definitely identify this and this case. And probably mostly about, as I told you before, 90% of the people are identifying these type of cases, that is severe periodontal cases. And these are cases probably, even if you refer to a periodontist, he is helpless. So try to identify disease at the most early stage so that you as well as your patients are most benefited. Now, for a perfect smile, the white and the pink should blend in perfect harmony. This is where I've spent all my career, Anu Dental College. And on behalf of everyone watching, I thank once more Online Dentistry. And I thank each and everyone for watching and listening to me. Thank you. Thank you all. The forum is open for questions.
Thank you so much, sir. It was indeed an amazing session that we got to know about periodontics. We never knew that it could be so simplified. We always took it as very complicated thing, but it was very simplified by you. Thank you so much for the sessions. I request all the participants to put up their questions. Sir will be taking a few questions now.
Devika, can you take up the question that have been already put forward?
Yes.
I can see my old teacher, Dr. Baby John, principal of Vinayaka Mission Dental College, waving at me. Thank you, sir.
Sir is there, then definitely we should unmute sir and ask sir. Sir is there?
Sir is there, yeah.
Oh, great. There you go. Would you please unmute sir? Baby John, sir, please, sir.
Yeah.
Sir,
Can you hear me? Thank you. Good lecture, Dr. Jose. It was very simple explanation. Now, I think if you could add a little bit of the limitations of laser in this pocket eradication, or how lasers can be used to what level, that will add a little more to the general practitioners so that they will know where to limit lasers.
Good question, sir. Lasers have always been a controversy in terms of with periodontists mainly. Okay, with general practitioners, it's been a hit. With non-periodontists, it's been a hit. I know lasers have been marketed to the next level, but to my experience, I'll tell you what lasers does is it is not going to be as effective as your thorough scaling and root planing. Now, lasers are effective in such a ways. Minor surgeries, I'll tell you, lasers are good. photodynamic therapy where we can eradicate some of the periodontal pathogens. It is good. It provides biostimulation. It is good. But even minor surgery, I'll tell you, if you are comparing laser with electrosurgery, now electrosurgery will work a much better way. It like you will have to give a local anesthesia. Even if the laser people tell you that you don't have to give a local anesthesia, ultimately you will have to give a local anesthesia. Then the speed of doing work is much reduced with electrosurgery. That is what I feel. But depigmentation cannot be done with electrosurgery as such, but that for that you need a laser. Other than that, laser is much hyped. That is my personal experience, and that's my take on laser, sir. If you want me to add something more, I...
Thank you so much, sir. And special thanks to Dr. Joy Baby, sir, for mentioning this and bringing this up.
Yes, Dr. Sunil sir. Sunil sir is also from Vinayaka Mission Dental College. Sunil sir, are you there? You want to add anything on to this, sir?
Good evening, all. Good evening, sir. Wonderful lecture, sir, on perio. You kept it really simple and very easy to understand. Thank you so much. No, sir, I wouldn't want to add anymore. I thought sir had covered it very easily and very simply so that all of us could understand really well. Thank you, sir, for the wonderful lecture. Thank you.
Thank you, Dr. Sunil.
Thank you so much, sir. Should we take the questions now, sir?
Yeah, please go ahead. So many questions are there in the chat box. Please do that.
Yes, sir. So the first question is the role of local drug delivery, sir.
Look, local drug delivery is considered as a non-surgical treatment. Okay, I told you, like if we find early periodontal lesions, I mean a lesion, probably in some cases, some patients will need a surgery. Okay, but they may have some systemic diseases which may contradict surgery. So in that, you can keep the lesion to a certain limit by adding local drug delivery. That is one thing. The second thing is, along with your non-surgical therapy, if you are adding local drug delivery, you are really able to control your microbes, and you can control pathology there, especially in case of deep periodontal pockets, deep periodontal abscess. Now, just your instrumentation is not going to reach the most apical aspect of the tooth. In that aspect, you can add local drug delivery. So one of the most important aspect about local delivery is that when you give drugs systemically, when you give, that is why I told you, you have to judiciously give antibiotics. You don't have to give antibiotics in all the case of periodontitis. When you give, you are subjecting the patient to a lot of systemic side effects. Now, these side effects are being reduced. When you give a local drug delivery, you are particularly giving this drug at that particular location, and this remains sustained over a period of time, and this drug concentration is there in the GCF for a long period of time, and you get much 100 times much higher MIC, minimum inhibitory concentration, in the GCF when you compare it with systemic administration. So not in all cases, but the problem is these local drug delivery agents that you're talking about. You have some of these local drug delivery agents that are available in the India, which are much cheap, but even though it may cost about 500, 750 rupees, which you can do in a 1 or 2 pockets. But the other local drug delivery agents which are available in the market are very expensive. So one thing which I would suggest, these are not local drug delivery agents. You can use your Metrogel DG gel. You can take, you can put it into your a syringe and you can inject it. This acts as a local drug delivery agent, but it is not an accepted one. Okay, that is all topical. All local drug delivery agents are supposed to stay in the pocket and release drugs over a period of time, which is not going to be done by these agents, but this work. Okay.
Thank you, sir. Thank you so much.
Yes,
we have another...
sir, one question from YouTube. Can you take one question from YouTube?
Sure, definitely.
Yeah, we have around 80 participants from YouTube, sir. So one question is Jaimara Singh is asking is, in a case of subgingival restoration, placement for crown margin where should the margin be placed on restoration or deep subgingivally?
Can you just repeat the question, Marmo?
In the case of subgingival restoration, placement of crown margin or the restoration margin, should the margin be placed on restoration or deep subgingival?
Look, you ask any endodontist, you ask any periodontist, they will say that the margin has to be on sound tooth structure. Now, when it is too deep subgingivally, can you expect? No. You have to make a compromise. Probably in that areas, you will have to give a margin which is not subgingival. That is my take on that. But the thing is, your restoration, subgingival restoration, there has to be perfect. It should not be overhanging and it should not violate the biologic width. These are the two important aspects that you have to consider. Apart from that, if you go do too subgingivally, again, you will have to remove a lot of bone and you will have to, the gingival recession will happen over there. Probably that is probably going to be non-aesthetic. At the same time, it is not practical on a day-to-day basis.
Thank you, sir. Thank you. Devika, you can go ahead. Zoom questions.
Sure, sir. Thank you, sir. One more similar question to the first one was role of doxycycline in periodontal diseases.
Doxycycline, look, all tetracycline group of drugs are very effective in periodontal disease. They are across different spectrum we use. We use it for host modulation. We use it for local drug delivery. We use it systemically. We use it for root biomodification. All these different ways we can use it. But doxycycline is one drug that is good. It's effective in controlling periodontal infection. But the problem with doxycycline, when you ask the patient to ingest a lot of water along with that, because it gets stuck with your with the intestine, I mean, or the GIT tract. That is one thing. It is an effective drug that can be used. But when you use, and it is effective against aggressive type of periodontal disease also. You can definitely. But one thing regarding antibiotics, if you ask me which antibiotic to prescribe in periodontal infection, I won't suggest doxycycline. The evidence says that amoxicillin with metronidazole is the combination is the best for periodontal infection when it is indicated.
Thank you, sir. Thank you so much. Another question by Dr. Roshni is refractory periodontitis. Could you put some light on refractory periodontitis?
Good question, Roshni. What is refractory periodontitis? It is something that is not going to respond to any form of treatment. In my personal practice, I'll tell you, I have seen a case where one of my senior practitioners done a flap surgery. It was in relation to a canine. I did flap surgery 2 times for him. Later, I did root canal for him. And then finally, after I had extract. So there are some cases which does not respond at all. But I'll tell you, it's very few cases that does not respond at all. And the reason we don't know. But when you look at the new literature and all, you don't find they have not put refractory cases. But you find cases in your practice which does not respond. But the percentage of those cases are very less. And I've seen that most of these cases are site specific.
Thank you, sir. So another question is about antibiotic administration in case of abscess. Told about gradual administration of dose. Please explain.
I never told about any gradual gradual dosage. What I said is, if there is an periodontal abscess, just because there is an abscess, you don't need to give an antibiotic. There is absolutely no need to give an antibiotic. Only if there are any systemic problems associated with that. Only if there are any systemic involvement, any debilitating problems like diabetes or other systemic conditions, you need to give antibiotics. If you are giving antibiotics, suppose you're giving antibiotics, amoxicillin, you give a loading dose, and then you continue with the normal dose. Amoxicillin, 1 gram you start, then you continue with your 500 milligram dose. Only in indicated patients. Okay.
Thank you, sir.
Otherwise, you're drained at least.
Thank you, sir. One more question is, after complete supra and subgingival scaling, has polishing with prophylactic paste any positive benefit?
The problem with scaling and root planing is it will definitely leave a rough surface. So definitely polishing is going to help. Polishing with polishing cups or brushes along with prophylactic paste is going to polish the root surface in such a way that it is less conducive for more of plaque accumulation. It definitely helps. That is a part of facement therapy.
Thank you, sir. So another question, what is your view on deep margin elevation during composite restoration?
Deep margin elevation is something that is being practiced nowadays by endodontists and respiratory dentists. Now, my take on deep margin elevation is deep margin elevation can be done. As I told you before, there was a question asked on whether you should place a subgingival margin of a crown. Okay. Only thing is, it should not violate the biologic width. That is my only take on that. Other than that, that is the only thing that you can do. You have to elevate the deep margin to provide a good restoration for the patient. You can do deep margin elevation, but the biologic width has to be taken care of. Otherwise, even if your restoration is going to cause a periodontal problem there, which may lead to a pocket, may lead to a gingival inflammation over there.
Thank you, sir. One other question is, use of hydrogen peroxide and betadine in combination while curettage of lap surgery is judicious or not?
Look, you come across different patients, and the only indication, one of the most only indication as regard to what you say, hydrogen peroxide is mostly in case of ANAG or necrotizing ulcerative gingivitis, okay, where you have a pseudomembrane where you use this 3% hydrogen peroxide, and this will oxygenate that area and will provide nascent oxygen in that area and provide that anaerobic environment is being liberated. Okay, that is something that happens. Other than that, my take is betadine is effective, and especially in this COVID era, betadine is more effective. Okay, you give a procedural rinse also, but you give a chlorhexidine. Chlorhexidine is an effective, a proven literature. You have support of the literature with regard to chlorhexidine.
Sir, one question, sir, from YouTube is, sir, what is the regime for doxycycline?
Doxycycline, you can start on the first day, 100 milligram twice daily, followed by 100 milligram for 4 days. That is a usual regime. The first day you can give 200 milligram, and then you can give for 100 milligram for 4 days.
Thank you, sir. Sir, another question from YouTube is Mansi Tukal Chandra is asking, sir, chlorhexidine is prescribed for how many days? Maybe the mouthwash, sir. After the first round of scaling, can prolonged use also destroy normal flora?
I don't know about the loss of normal flora with chlorhexidine, but the problem is if you use chlorhexidine over a period of time, there are a lot of side effects associated with chlorhexidine. And one of the most important side effects associated with chlorhexidine is bad taste, staining, all those things. So you don't advise. What I advise in my practice is I'll advise the patient to use one tube of that. What do you call that? One bottle of one bottle. That is what we advise. We don't advise it long. Even after flap surgery, we advise them patients to use it for 1 week, or till that one bottle is over.
Okay, sir. Mansi, any more? I mean, Devika, any more is there?
Yes, sir. A few questions we have. So one more question is, role of plunging and root contour rotation of tooth causing periodontal disease and management.
Pardon me. Can you repeat the question?
Yes, sir. Role of plunging and root contour rotation of tooth causing periodontal disease and management. Sir, like,
I think the person who was asked the question is talking about food impaction. Now, food impaction is one of the most important. I think I have shown you many cases here which has caused periodontal problem due to food impaction or loss of proximal contact. Now, when you look at the modern literature or when you look at newer textbooks, you don't find plunger cusp. That is something that is there. Okay. But one important aspect is this proximal contact or the contour relationship of the between teeth has got a determinant effect on the periodontium. If there is food impaction, definitely there is going to be a pocket. Now, if you are going to treat that pocket, and then if you are not going to address the food impaction there, the problem is again going to recur. That is my take on that.
thank you, sir. Another question is, which cases do we need to suggest interdental brushes, what brand, and how to select sizes?
Now, I'm not here to address any brand or anything, okay? So any brand is best depending upon what you see on the patient. Now, depending upon the size of the interdental area. Now, if it is tight contact, probably you can definitely go for flossing, but depending upon whether it's a 30% loss, 50%, 70% loss, you have interdental brushes that are available at different sizes. So depending upon the size of the interdental area, you have to select an appropriate interdental brush for the patient. Umpteen number of interdental brushes that are available in the market.
Thank you so much, sir. That
Sir,
was
one more last question from YouTube, sir. One very commonly confused question, sir. With that, we will wind up, sir, from YouTube. Is that, sir, which is good to use, Rexidine or Listerine mouthwash?
Look, Listerine is essential oil, and the other hexidine is chlorhexidine. Now, if you ask any periodontist, the first thing he's going to say is definitely he'll say for chlorhexidine. Now, chlorhexidine, we have data that it is going to, I mean, it acts very well against periodontal pathogens. We have all the data regarding that. Essential oils to an extent acts, but then it doesn't have that much scientific literature supporting its use for periodontal lesions.
Thank you, sir. By the time you was answering this, we have another question, sir. Should I take that?
Definitely, take that.
How to manage for root contour causing food impaction? That is.
Pardon me? Root
How to
contour.
how to manage root contour causing food impaction?
I don't know how root contour is going to, I can understand crown contour causing food impaction. I don't know how root contour is going to cause food impaction. I am totally unaware of it. I stand to be corrected on that also. And I think I don't have any answer for that.
Sir, one more question. When will we place crown after crown lengthening procedure?
Good question. Very essential. I mean, that's a question near of the hour. We look, if you are doing a crown lengthening procedure, the first and foremost thing I would like to do in anybody's practice is give a temporary restoration when the patient comes for suture removal. That is after 1 week. Let that patient use that temporary restoration and let the gingival and the periodontal tissues heal in relation to that crown lengthening, I mean, to that margins of the restoration. Wait for 2 months, then you take your final impression. So 2 months after your crown lengthening is the answer for that.
Thank you, sir. Thank you so much. I hope sir has cleared all the queries. For any queries, you can contact us on our WhatsApp groups and we'll be reverting back on the same topic. Thank you everyone for the great support shown. Thank you so much, sir. It was a great session. Our eyes are opened for periodontics for sure, sir. We all will be using your tips for the general practice. Thank you so much, sir. Have a good night, everyone. Devika Vaswani signing off.
Thank you, Divya. Thank you, Dr. Chavi.